Good afternoon. I am Steve Hargatai, a practitioner in a dental field called orofacial pain. I am sorry I could not be there in person at the Harp Festival. I would like to thank Anastasia Pike for the invitation. I have treated many musicians over my career for various pain conditions. My goal here is to share what I have learned over the years. My hope is the information passed here would be helpful to you if you find it applicable. As you see here in the disclaimer, that this information is generalized and not meant to specifically diagnose a listener with a particular condition. People are complex and have individualized medical and personal histories. So the specialty of orofacial pain has existed in an organized way for many decades, but it was just a few years ago that specialty status was recognized on a national level. The way our nervous system is wired, there are two main superhighways carrying pain information to the brain, and the cutoff point is roughly at the top of the chest bone. As you can see here, the yellow line. Thus, neck pain and headaches, as well as facial pains, all feed into a common part of the brainstem. A patient with jaw and facial pain also frequently presents with headache and neck pain. For the duration of the presentation, please be mindful of the following, and I will tie in the rationale by the end. Whenever you see the smiley face pop up, check the following. The smiley face will be your cue to keep your teeth apart, tongue flopped down, and maintaining good head posture. You could achieve this position by licking your lips and saying the letter N, or you could say the girl's name, Emma. That'll put your teeth slightly apart and tongue down. And I'll get back to this towards the end. And also be mindful of your head posture, that you're not leaning forward, that you're not tilting to one side or the other. So one condition to begin with is one called carpal tunnel, which is common in occupations where repetitive hand movements are required, such as a dental hygienist, or perhaps a pianist, or perhaps even a harpist. It presents as weakness or pain in the wrist. Could be some tingling sensations, could even feel numb. Essentially, it's caused by inflammation or pressure placed on the nerve coursing through the wrist called the median nerve. Its management is to reduce the activity that is responsible for this, or improving the ergonomics of that activity. Wearing a wrist splint would be accomplished via a physical therapist or occupational therapist, sometimes anti-inflammatory drugs called non-steroidal anti-inflammatory drugs could be used. Examples of those would be ibuprofen, naproxen, Mobic, just to name a few, or steroids or steroid injections. And if all that fails, surgical decompression with a hand specialist might be indicated. Amongst those musicians that play wind instruments or brass instruments, oh, there's our smiley face. That is your cue to check to make sure your teeth are apart, tongue relaxed. That smiley face is going to appear every now and then. So we're trying to catch you in the act of having your teeth together. They should actually be apart, and they should only touch when you're eating food. Nonetheless, amongst brass players, a lot of pressure is applied on the embouchure. I think I read the French horn, for instance, is 23 feet long if you unfurl it. So the management of this is some rest. They could do some buzzing exercises by detaching the mouthpiece from the instrument. And in cases of a tear in a muscle involved, which I'll show you in just a moment, sometimes surgical repair is necessary. So here is the muscle that makes you pucker your lips and apply your lips to an instrument. It's called the orbicularis oris. Among heavy strains, sometimes there could be a tear in that muscle, which could be repaired. Moving on to a few muscle conditions. The difference between a muscle spasm and a muscle dystonia. A muscle spasm is the simpler one that usually resolves on its own or with some minimal intervention. It manifests as twitching, spasticity, and pain is a result of repetitive use of a muscle that leads to muscle fatigue. That's a little bit different than a dystonia. A dystonia is an uncontrolled muscle movement, and it's kind of caused a little bit complex, but the brain reorganizes in a disorganized fashion. That usually requires a consult with a neurologist. But simple forms of spasticity could include modifying the activity, medications such as muscle relaxers, Botox into the muscle that's hyperactive, which would inactivate the muscle for about 3 to 6 months. This is a picture of my sister-in-law, so the most musical person in our family. So she is a soprano in the Hungarian National Choir. To touch on neck pain for a moment, there could be many causes for neck pain. It's almost like saying I have a headache or a tummy ache. Well, there could be many things that cause those things. One cause could be arthritis of the neck. If held in a certain position for many hours or days or chunks of your life, such as it might occur with a violinist that has their head off to the side. Could also occur in a secretary or somebody working on a computer screen, and they got the screen is not straight in front of them, it's off to the side. Could be impingement of nerves coursing through the upper arm called the brachial plexus. Sometimes plain old head posture would produce muscle fatigue. Any sort of occupational situation where you would be required to put your head in interesting positions, like a dentist or perhaps somebody wearing some headgear, things along those lines. The management of this is to improve ergonomics. Sometimes physical therapy is needed to regain strength and to retrain the patient to have better head posture. So your head should not be tilting off to the side. It should be sort of straight on. Sometimes acupuncture is helpful into the muscles if it is suspected that inflammation might be an underlying cause of the neck pain, particularly if there's an injury of some sort. Again, one of those anti-inflammatory medications we mentioned, i.e. Motrin or its derivatives, or sometimes muscle relaxers. And we'll talk a little bit more about muscle relaxers shortly. So, does anybody know how much their head weighs? Our head weighs about 8% of our body weight. So you could do the math for yourself. So I have a picture of this young lady in the center, and the landmarks to pay attention to would be her earlobe and shoulder. And as you can see, the earlobe is a little bit in front of the shoulder. So imagine whipping out your cell phone and start reading text messages. You probably will dive into the phone a little bit. So the picture on the right would be a way in which we try to retrain this patient to have better forward and back head posture. So we would train the patient to bring the earlobe back over the shoulder. You could do this at home by standing up against the wall. Make sure your shoulders and the back of your head touch the wall. That's a little bit natural. Now take one step away from the wall, and that should put your head in the correct position. The picture on the left shows some of the bowling balls we have in our clinic. So our bowling ball weighs approximately what your head might weigh. So I think this is a 12-pound bowling ball. You could get these for cheap at Goodwill or Salvation Army. So it's a good patient education tool. So this patient is holding that bowling ball forward. So her arms are going to get tired pretty fast. If she were to hold the bowling ball close to her chest, it would not seem nearly as heavy. So imagine your head as a bowling ball and how hard those neck muscles would have to work if they are not in the correct position. In other headache entity, we would find above that magical line above the chest is headaches. And headaches could be a whole other session in itself. Essentially, when we try to evaluate a headache, we try to look at some characteristics. Not just the intensity, 0 to 10, but how often does it happen? And we like to capture this data in a per month fashion, meaning how many days per month do you experience a headache? And then also duration. If you do get a headache, how long do they last? Some characteristically only last a few seconds. Some last about 30 to 180 minutes. And others, like migraines, last 4 to 72 hours if you go by the book. So the tension headache is the run-of-the-mill headache. The migraine headaches are a little bit more intense, last longer. There could be sensitivity to lights or sounds. There could be nausea and or vomiting. A migraine patient would have a tendency to seek a dark, quiet room and try to sleep it off. Another classification of headaches are the autonomic cephalalgias. So this is a headache that usually occurs just on one side of the head, but has super interesting features. Like on the side of the headache, your eyes would run, your eyes would be bloodshot, your face would be sweaty, your face would be red. And its worst version is called the cluster headache, a very intense type of a headache. These could be managed by medications in either an acute or preventive fashion. The usual way we think of treating a headache is acute management. Hey, I have a headache, I'm going to take something for it. That works okay, pretty well, if your headaches are few and far between. But if your headaches are daily or nearly so, it's best to try a preventive headache medication. And if you ask your doctor, there's a whole bunch of them. None of them sound like pain medications. So don't be surprised that a blood pressure medication or an antidepressant might be, or an anti-seizure medication might be suggested for migraine prevention. Other treatments could include acupuncture, could include, if you have a white screen that you're staring at, that you have a blue filter for those that have headaches associated with screens and light, or a simple daily supplement with magnesium oxide. Using that daily has reduced some headaches in some patients. Most orofacial pain clinics, actually probably all of them, deal with a certain degree on a condition called sometimes TMJ or TMD. TMJ is an acronym for temporomandibular joint, and TMD, teeth apart, stands for temporomandibular disorder. So just saying I have TMJ is acceptable as a layperson, but there's more nuance to that. So there's probably 30 to 40 conditions that could fall underneath TMJ. So we could become more specific when you get evaluated. Generally occurs more so in females of childbearing years. About 1/3 of the population might have quote unquote TMJ at some point in their life. Amongst that 1/3 of the population, 15% will have it recurring on a yearly basis. So when I said TMJ is kind of a catch-all term, some TMJ issues are indeed has something to do with the joint. Other ones have something to do with the muscles around the joint, and still further, something to do with the nerves that make the muscles move to move the joint. Okay, so it can be joint or muscle or nerve, and there are subcategories of each. Okay, so on the skull we have 23 bones, and the only one that moves is your lower jaw or the mandible, and it hinges right in front of your ear. So if everybody were to take their index fingertips, place it right in front of your ear, open and close, and move your mouth, you could feel that little ball move around beneath your fingertips. So that's the ball and socket of your TMJ. So you got one on the right side and one on the left side. There's muscles in the temples, on the outside of the jaw and inside of the jaw that are responsible for opening and closing the mouth. Over here on these diagrams developed by, in part by President Kennedy's personal physician, Janet Travell, we noticed that, or she noticed, that sometimes pain is referred far away. For instance, in these experiments, she put salt injections at the black X, obviously painful, but besides reporting pain at the black X, some patients felt pain in other areas recorded by red dots. So she took everybody's answers and superimposed them to create these diagrams. So what this shows in the lower image on this neck muscle that goes from behind the ear down to the clavicle or the collarbone, that when that neck muscle gets sore, it could refer pain to the jaw joint and into some headache areas. Same with the upper picture on your shoulder shrugging muscle called the trapezius, or the traps, as they say at the gym. When that muscle gets fatigued, it could refer pain again to the side of the head and mimic a headache, and it could also mimic a jaw pain. So as we move along with the next few slides, there is an assumption here on my part that your general dentist has already ruled out and examined and says, hey, it's not, you don't have any toothaches, you don't have any cavities, you don't need a root canal. The assumption is all that has been ruled out as pain sources prior to. Okay, so we now know that TMJ is rather not specific, nonspecific. TMD is a little bit better, temporomandibular disorder, but there are joint problems and there are muscle problems. Some of the joint problems include what occurs in the ball and socket joint of the TMJ. So in between the ball and the socket, there's a shock absorber called a disc. Okay, it's sort of a not quite cartilage, it's dense fibrous connective tissue technically. In about 1/3 of the normal, healthy, mind your own business population, that disc is in a forward direction. So when you go to open, 1/3 of you will probably experience a click. Or you might not actually feel it, but we might see it on an image called an MRI. So the click, minus any pain and minus any functional issues, does not require treatment all by itself. Okay, so again, 1/3 of the population has this. So it is considered a variation of normal for many people. A little further on the line, some people, the disc does not pop back into the place, so the click disappears and they could hardly open their mouth. That's called an acute closed lock. That might need some intervention. Then there's, besides your mouth hardly opening, there's the other issue where you open too wide and you get stuck. If it happens momentarily, we call it a subluxation. But if you're stuck wide open, like maybe you laughed too loud or you had a long dental procedure and your mouth is stuck wide open, the TMJ is actually dislocated. So usually with a dental maneuver, that could be fixed right quick. If your jaw is kind of sore, worse after a period of inactivity, maybe there's some crunchy sounds like Rice Krispies or crepitus, and there's radiographic evidence to prove it. Osteoarthritis could occur in the jaw joint. Sometimes just self-help exercises and an occasional non-steroidal anti-inflammatory is all that's really needed. And surgery is rarely needed. But the biggest category is muscle diagnoses. So sore chewing muscles or sore neck muscles. Again, anything above your shoulder blades would be fair game. So if it's just localized soreness to touch, we call that myalgia, and a doctor would touch certain muscles with enough pressure to make their fingernail blanch. But besides having pain just where you touch, if the pain kind of shoots to other body parts, like if I touch the side of your face and it shoots up to your temple, we change the nomenclature a little bit, and instead of calling it myalgia, we'll call it myofascial pain. In myofascial pain, the muscle may even have a knot in it. These are sometimes called trigger points, where touching it sets off pain to remote areas. So those are the two top muscle diagnoses we run across. So the management of TMD is a good dose of self-help exercises. The self-help exercises we were talking about earlier. So when you see that yellow smiley face, okay, shoot 3 puffs of air through your lips, or say the girl's name Emma, or you lick your lips and say N. That should put your teeth a little bit apart and tongue down. And it's best to have some kind of reminder to remember to do this, because what are the chances of you just spontaneously remembering? Probably not very high. It's not very high for me. So it's good to have some sort of reminder in your environment to trigger you to go through these. And we'll expand on that in just a bit. Muscle relaxers, like some brand names like Robaxin, Flexeril, Tizanidine are examples. Or ultrasound to muscles, basically is a means by which we could deliver heat to a muscle to allow the capillaries to expand and wash away the old irritating products inside the blood and bringing in fresh blood to the muscle, which is way less irritating to those muscles. If there is a trigger point, like the patient has myofascial pain, either dry needling or injecting the trigger point with a needle and a little bit of local anesthetic to make the pain go away, along with some stretching, could help break up those trigger points. Patients in chronic pain and with TMD often have sleep issues, so either some sleep medications could be trialed short term, or just basic sleep hygiene is even best to try first. So your sleep schedule, what's more important, going to the bed the same time each night or waking up the same time each morning? Research says it's waking up the same time each morning. It's called a morning anchor. Um, Also, sleep restriction. Hey, you go to bed and you're not asleep in 20 minutes. Well, you should get up, go to a different room, and do something quietly like read and watch TV until you feel sleepy again, and then return to bed. Again, if you're not asleep in 20 minutes, you leave the bedroom. So basically, we want the bed to be a cue that, hey, this is where sleep happens. And if it's not happening, then you go somewhere else. By the way, while you're in bed, please don't watch TV, don't look at your cell phone, don't pay bills right before bedtime, things along those lines. Sometimes people bring their teeth together even when they're sleeping. Okay, so they do it during the daytime, which is what we're trying to address with the smiley face, but it might occur at nighttime. So for nighttime, we might consider, again, a muscle relaxer or a night guard, like you see one here with the red background. I prefer the ones that are rigid. The ones that are soft are kind of like a chew toy. So what does a dog do with a chew toy? Well, it likes to chew on it. Humans, same thing. So I prefer the hard night guard. A lot of patients with chronic pain and chronic TMD, if it's going on for more than a year, there's a high chance there might be some anxiety or depressive diagnoses as well. If they are present, they should be co-managed at the same time for optimal results. So in my clinic, the name we gave to this exercise of keeping your teeth apart and tongue down, we called it PAT, or Positional Awareness Training. So again, it involves finding yourself a reminder. Say the girl's name, Emma, or you could see a cupcake with a candle on it. So blow it out with 3 gentle puffs. So besides teeth apart and tongue relaxed, your lips and face should be relaxed. Okay, so you're not shouldn't be making any goofy facial expressions. You could take your hands and drag it down the side of your face and try to eliminate any unnecessary lines. Okay. We talked about head posture. We demonstrated with the bowling ball what that might look like. Here's some of the muscle relaxers I mentioned earlier, along with their generic names. The generic names are a little bit harder to pronounce, so I went with the brand names. So usually a combination of PAT and muscle relaxers, that takes care of this issue for a good chunk of patients. I also wanted to mention diaphragmatic breathing. So anybody who plays wind instruments has been, or is a singer professionally, has been trained by their instructor to breathe with the diaphragm so you can get more air in and express and hold a note longer. Sometimes patients in pain or with adverse histories in the past have been sort of sensitized, and we've switched from a diaphragmatic tummy breathing style more to a chest style of breathing. So breathing with your chest has some consequences. First off, the muscles involved with breathing with the chest involve some neck muscles. Those are very inefficient long term. So if you breathe with your chest a lot, chances are pretty good you have some neck pain that could actually even lead to headaches. It also serves as a form of stress management. So we have an autonomic nervous system that jazzes things up, and it has a counterpart that kind of calms things down. So one way we know how to bring about the part that calms things down is to breathe more with the diaphragm. Okay, so if you breathe like you're relaxed, your autonomic nervous system often follows suit. And of all the vital signs we have, blood pressure, pulse, body temperature, respiratory rate, the only one we could sort of control, at least in the short term, is respiratory rate. So you could practice this by putting a hand on your chest and another one right above your belly button. And as you breathe in, you try to raise the hand on your stomach while not raising the hand on your chest. If you have a hard time controlling the chest aspect of breathing, you could do what the young lady is doing in the right side of the diagram. You could put your hands behind your head, lock your elbows out, and that should force you to breathe more with the diaphragm, and you'll get more comfortable with the mechanics. This takes some practice to get used to this. So the main pillars of improvement include self-care, which we covered. Sleep is very important, nutrition is very important, and exercise is very important. So those are the pillars of improving and with chronic pain conditions. Then, of course, there's the things that are confounding factors that actually make things worse. Smoking, caffeine, poor sleep, skipped meals. So if you have dinner at 6 p.m., you skip breakfast, and you don't have anything till noon the next day, your blood sugar levels are basically in the pits, and having low blood sugar is called hypoglycemia, and that's known to be a headache trigger in many patients that suffer headaches. Now, if you have facial pain or TMD, and it's been going on for a very long period of time, and you have any of these following conditions, chances are that it's going to take a little bit more time and a little bit more intervention before you start feeling better. So if you have a pretty robust headache history, you might become a TMD patient. Interestingly enough, patients with TMD also have a higher than statistical average, and this is proven by much research, of having these other pain conditions like irritable bowel syndrome, which is a mysterious gut pain, but the doctors don't know why. Fibromyalgia, your whole body hurts, but all the x-rays and tests are normal. Sleep issues, very common in the chronic pain population, as well as some behavioral health diagnoses. So for optimal results, all these should be addressed at the same time. Okay, so if you have these 5 issues along with TMD as issue number 6, we're going to have a hard time making the TMD better unless some of the other 5 are also addressed, as an example. You may not have all 5, but maybe you just have a couple. And if you're not in any pain, congratulations. There are a few things to keep in mind as far as prevention goes. Okay, so I think if you get very good at keeping your teeth apart and tongue relaxed, I think there's a pretty good chance you could keep the TMD away. You could engage in some diaphragmatic breathing as a form of relaxation as you go to bed, or if you're just sitting on the couch watching TV. Hey, that's a perfectly great opportunity to practice diaphragmatic breathing. That kind of sounds like a harp, does it not? All right, so that little musical chime is my contribution musically to this festival. Thank you for your attention. Again, thank you for the invite. I wish I was there. I think I'm a better speaker in person. Just didn't work out this time. But thank you, everybody. Enjoy the rest of your day.